Good morning, everybody, and welcome to our session Cooperating on Health Workforce Mobility in Europe, EU and Global Cooperation for Health. And we all know the health workforce is one of the key themes, topics of this conference. It's almost like a red thread. There's no session in which we are not talking about the health workforce, and for good reasons, because we are all facing at the moment a health workforce crisis. May have different faces in different countries, but almost all of the countries are struggling massively. And we had yesterday a great session actually on attrition and attraction. How do we retain, how do we get health workers into hospitals, healthcare facilities, into the primary care sector, but also how do we retain them? That was yesterday's topic. And today we will discuss another aspect of the health workforce crisis, and that is the mobility. It's the internal mobility, the maldistribution, so that places are underserved, that certain services are not available because the health workers are not there, or particular parts of the health workforce. And we will also talk about the maldistribution between countries, and how this is linked. And for this purpose, we have combined two excellent panels. The first panel is a little bit more technical. So we will we will ask Corinne from VEMOS to give us a little bit of overview on current projects, because the EU has funded a number of projects on medical deserts, on maldistribution, but also on the link between the maldistribution and the international mobility. Please, Corinne, take a seat. Then we have Irene. It's a great pleasure to have you here from the European Labour Authority. You give us a little bit of big picture, because we are assuming it's great to have mobility, that we can choose to work in other countries, but is it really working at the moment for health systems and patients and for the professionals? Can we have it better, actually? And you will give us an overview how it actually looks at the moment. Then we have Gediminas. Gediminas, great pleasure to have you here. Gediminas is not only a professor of economics, but he also was Minister of Health at a time in Lithuania. And you will report a little bit from a project working together to address healthcare workforce mobility in Europe, and to see how can we use it actually to fill gaps and to irrigate the medical deserts in some of our countries. And last but not least, I'm very happy to invite Thomas Zapata from the WHO. You will give us a little bit of perspective from WHO. You may remember that many years ago, WHO actually launched a global code for recruitment of, a good code, how to recruit people from other countries and from which countries you shouldn't recruit them, actually. And we will discuss this, whether it works, whether countries are compliant and so on. And then after this, we have a second panel, which is more political, and I'm very happy to welcome SARA CERDAS, MEP for Portugal. SARA, I saw her, I think she's in the press center at the moment, so she will be with us in a second. And VYTENIS ANDRIUKAITIS, the former Commissioner for Health. But now, first of all, the panelists, please come here. And Corinne, may I ask you to start right away and talk a little bit about the medical deserts? And as we discussed, of course, there's a lot of problem analysis, but we would also, I know that your projects are actually not only looking at the problems, they are very practical oriented. They are trying to identify what are the deserts, what specific characteristics do they have, but also what can be done actually. And you work very closely with member states, with countries on these issues. Please, Corinne.
Does this work? Yes, it does.
It does.
Thank you. It's the WHO Global Code of Practice on the International Recruitment of Health Personnel. Fun fact, we use this one in quizzes on global health when we organize them. It's always, nobody actually knows it, but that's the one. Yeah, thank you for this opportunity, because it's, yes, we have recently concluded the project on medical deserts. It was called AHEAD, Action for Health and Equity, Addressing Medical Deserts. And we're also in the conclusion phase of a project that we call Pillars of Health, for obvious reasons, addressing the internal EU mobility and migration. Now, the interesting thing is when you do these two projects at the same time, you see that the unavailability of health and care workers at the micro level, so in medical desert areas, are actually, and the unavailability of health workers at the macro level, they are closely interlinked and have at their root causes the same push and pull factors. And these all come down to what Thomas also yesterday in the plenary elaborated on: working conditions, living wages, career prospects, continuous professional education, being able to do your job in a safe and secure environment free from violence and harassment. So, but when you see how the mobility flows go, they always leave behind the most vulnerable and disadvantaged communities or countries. And then you start thinking like, okay, so if we're all struggling with staff shortages, and then they end up in the wealthiest nations or the wealthiest regions, how can we tackle that? And the interesting thing about mobility also is that it is, and Thomas mentioned it as a factor of attrition. You lose people, but in other parts of the world, they are your supply. So how is that fair? And especially in the European Union, where we have vowed to prosper together in solidarity, I think that is something that should be put on the table very emphatically and be discussed.
Corinne, can I ask you back, if I understand you correctly? It means that medical desert, the root cause is there are push factors. Because working conditions, career prospects, all this kind is not. So these are very domestic issues, actually. These are, you could say, health policy failures in the country, isn't it?
Absolutely, absolutely. And what we did in the AHEAD project is we worked with, in the medical desert areas, with a methodology for participatory policymaking, where we also, made use of wisdom of the crowd, so to speak, the local level health and care workers, local communities, local duty bearers, to understand what the exact problems in that specific area was or were, because there's also always multiple, and then try to see what will work for them, what they can do also in their communities, but also what they need from the national level. And then when we escalated those discussions to the national level, we would also ask, well, what other means at the national level can you use from the EU, instruments, money, whatever support that can help you?
Just for our understanding, Corinne, medical desert is a great term, but what does it actually mean for patients? You know, I mean, is it a problem of quality, of access?
It can be anything, actually. We worked in 5 countries and they were so different. Excuse me. We worked in the Netherlands, very small country.
Hard to believe that they're medical deserts.
Yeah, well, it's all relative. Huh? What do you compare the indicators with? We worked in Italy, in Romania, Moldova, Serbia, and you can really easily understand in Italy you have these mountainous areas, accessibility issues. But for example, in Romania, where the health system is very much focused on secondary care, there was much more the emphasis on the primary care. And we know that the primary health care is actually the fundament of a resilient health system. So the calls there were much more like invest in this primary health care, and not so much in the specialized doctors, but the nurses, the community care, and stuff like that. So it means for the patients and the communities that either the care is not there, or it's there erratically. Some days of the week they are there, others they are not. They're not culturally appropriate also sometimes in some cases. So they don't feel at ease actually seeking the health and care. So yeah, lots to be done there.
So thank you so much for this. So clearly some clarity on the push factors which make people go across borders to other countries. And now I would like to ask Irene to give us a little bit of an overview on the labor market. And as I said, we have a bit of the feeling that mobility is great. We have the Professional Qualification Directive, which makes it relatively easy for the so-called regulated professions to work in other countries, which are doctors, nurses, midwives, pharmacists, and can I believe this? dentists. So these are the five professions, but still we feel it's going into the wrong direction. And I mean, Corinne was just saying there's a medical desert, you know, and people leaving because the working conditions are not so good, and they are leaving for more affluent countries, you know, where the grass seems to be greener at least. Please tell us a little bit about our labor market here.
Yes, good morning everyone, thanks for having me. Before I answer that, let me say 3 words about the European Labour Authority, because you might not be too familiar with it. One reason for that is we're very young, we're very new. So the ELA is a formal agency of the European Union, and we have been only established in 2019. We are operationally now working for 2 years, and our objective is that we facilitate intra-EU labour mobility. So we are here to help the European Commission and the member states to make labour mobility working better, and notably also working in a fair way. Now, to come to your question, so what we do know as regards labour mobility for the time being is that we have about 10 million Europeans who are so-called movers. That means they are living and working in another country than is their original place of birth or citizenship. So that's a big number. But about 80% of them are in employment, so they are integrated into the labor market. But when we look into the sectors and the occupations, actually the health doesn't look too good as regards the movers. So they are not very prominent in these main occupations and sectors where we have the movers. If we are looking at another concept, which is called the cross-border workers, so are the ones we are, for example, they live in Luxembourg and they work in France, and they commute daily or weekly and crossing the border for work for that reason. Here the situation is different. Here actually health sector is much more prominent, and that seems to be working better. And I think that goes back to what was mentioned before, labor shortages and working conditions. So we are also responsible for providing regularly data on labor shortages. And what we do see here is that health occupations really year after year end up on the list of the top 10, 15 occupations that are on shortage in many countries. So to give you just a bit of a sneak preview of the very fresh data that was only collected a few weeks ago and will be published only beginning of next year. So you're the first ones to hear that. So what we found here is, for example, that specialist medical practitioners have been identified as shortage in 16 out of 31 countries that we are investigating within Europe. Then we have in 15 countries shortages in nursing professionals, healthcare assistants, and general medical practitioners. And on the top 3 place, we have in the 11 countries home-based care workers. So it's in literally half of the countries that we are investigating. A good number of the health professions are on shortage. And not stopping here, we also ask them, well, kind of, is it a normal shortage or is it a really severe one which impacts the working of the society, of the economy? And in about half of the countries where these professions have been identified as a shortage, they are additionally identified as a severe shortage, so having big impact.
The talk of the health workforce crisis is not talk, it's reality, at least for half of the countries there. Yes. Very good, Irene. And I mean, you're doing this great analysis, and you see, and we've been discussing about the numbers actually yesterday, but also what can we do about the mobility? You feel that the mobility in border region is quite intense and probably quite okay, but the rest is not. What is your perspective actually on the mobility? Because we all have different ideas about mobility. Some, I think, in the past, OECD thought mobility is great because it's a market, and the more mobility, the better. We are a bit skeptical sometimes because we feel we need to see that the mobility delivers on the health system's goals. So what is your perspective on it?
Yeah, well, from a labor market perspective, we are of course biased, but we think it's a big achievement of the European Union that we have this single market and that we make it possible that people can move and that employers can find workforce literally everywhere rather than just locally or in their country. But what for us is important is that it is good mobility, that it is fair, that it is a win-win situation for the employer and for the worker. And with our mandate of facilitating the intra-EU mobility, when we are looking at this data that I just cited, we are particularly looking as, is it possible, do we have for a specific occupation a shortage in one country and a surplus in another country, and we can encourage these workers to go there where they are needed. And overall, when we are doing this analysis, and this is now referring to last year's data, because as I said, this year's is very new, so we haven't gone that step yet. So in last year's analysis, we found for 300 occupations across Europe this possibility that you could do this cross-border matching. But again, for the healthcare workforce, it doesn't look good. So I only found 3 examples. That's ambulance workers, health associate professionals, and medical secretaries, where there really was a shortage in one country and surplus in another one. So I think this is telling that it's a structural shortage.
Actually, I think it goes probably in the other direction. Thomas was yesterday presenting figures on Romania and showing that Romania is educating so many doctors actually, but actually they end up somewhere else, not working in Romania, you know, and they are quite needed in Romania. So one of these examples where it doesn't quite work at the moment. Yeah.
But I think there are possibilities to help. So one example. There is, for example, a network which is called EURES, the European Employment Services, which is not new. It will celebrate its 30th anniversary next year. That's a network of public and private employment services in 31 countries in Europe. It has about 250 member organizations. And on the one hand, there is, we call it a digital face. There is an online portal which has a large number of job vacancies as well as curriculum vitae. So candidates in there, and we can do matching between 2 of them. And again, just to give you a few numbers, we have about 7% of the employers that are registered on that digital platform that come from the health sector. And in August this year, we had about 50,000 vacancies in human health activities and about 160 CVs of healthcare associate professionals and 180,000 CVs there from healthcare assistants and care workers. So there would be possibilities, but the problem is the 2 sides need to find each other. So another pillar that we are offering next to this online portal is taking advantage of these 250 member organizations, which have about 1,000 advisors placed across Europe, which can give local advice and support to the job seekers and the employers to find each others. And they are also, for example, organizing local recruitment fairs. We call them the European Job Days. And that's physical events where they can meet each other, they can have first interviews, they can have discussions, and this is then also facilitated by advisors who can give more professional advice. And I think that's important to get aware that these tools are available and that there are possibilities, even if it is not huge potentials for this matching that we find, that it could be supported further.
Irene, thank you so much, and it's really great that the European Labour Authority is not only doing the analysis and crunching the figures, but also thinking about, you know, how can we improve a little bit the market. Although I think it's a tough business, you know, because how do we get health professionals into countries where there are already push factors because domestic policy is not really addressing working conditions? Gediminas, that's the moment where I would like to bring you on board. You are former Minister of Health in Lithuania. You are Professor of Economics. Lithuania is a small country. Even when a large country recruits small numbers, it hits you instantly. And also there's quite a difference in affluence between, let me say, Lithuania, France, Germany, Belgium, the Netherlands. And they have large labor markets, you know, we're very hungry. And we have heard even the Netherlands, you know, is a little bit concerned. Please fill us in.
Thank you. So, as you referred to my background as kind of economic teacher, professor, yeah, so I would like to start from some maybe a bit provocative figures about capital flow. Like 50 plus years we have this theory of human capital, yeah? But unfortunately, in mainstream research, in policy debates, it's not often that people talk about movement of people. And just example about Lithuania, I would try to show that even small country really indicates quite big figures, and that may be of interest for international community as well. So according to our data, what we collected from 2004, when Lithuania entered the European Union, to 2018, it was last data available for us. We lost about, not lost, but exported to our countries like 500,000 people. And if to measure according expenditures on education of those people and upbringing of those people by their families, it's like 80,000–90,000 euros per one emigrant, and multiplication of those two figures gives us 36 billion euros of outflows of human capital.
So it's lost investment. And,
you may say.
Somebody else is...
But of course, we are gaining from foreign direct investment. We are gaining, as not very rich country, from European Union. We are paying less to European Union budget when receiving. So those net inflows of capital are roughly 25 billion euro during the same period. So difference 36 means 25. We have 11 billion losses, you may say. Of course, it's not so simple. It's because immigration not always is a bad thing. We already started discussion with, but still it's just the idea that you should think about those issues, because really we are big and probably a bit not properly reflected by our politicians and even our research community. Second thing, what from our project is quite clear, that migration or mobility has a lot of positives. We know that it's one of the greatest advantage of our European Union, but sometimes it has also negative aspects. Not always European value added for health is created. Example very simple. You have, for example, surgeon in one country. He goes who really saving life and goes to richer country and works in some cosmetic surgery or whatever. So, and salary may be even higher. So it's kind of win-win for recipient country and for the worker, but probably more loss for in health for source country. And maybe even we put together losses in one country and gains in other countries, because this plastic surgery is not so much about health. So maybe even overall in Europe, if to put those figures together, we are losing overall. So
so you're saying you're losing somebody very useful in your country, and it's not necessarily doing something very useful in the other country.
Exactly.
Okay.
And that's again, it's quite interesting field for research, but also for political debates, because we are somehow avoiding those issues, saying, okay, this is fine, and this migration is great, and we should encourage. It's true that it has a lot of positives, but to understand that there are issues beyond those positives also very important. And now just just we're in the morning after this yesterday celebration. So just to awake people, now we are having this war in Ukraine. So a question to the audience, how many health professionals left Ukraine for the EU during those 2 years?
1 million?
No, I think problem is that we do not know, It's already a problem. But again, in Lithuania we have statistics by professions, of those refugees. So it's 4% of in Lithuania from all people who came from Ukraine during this war period. We know that refugees in European Union are roughly 4 million, so 4 multiplied by 4%, it's 1 160,000 people. And now second question, let us say, it's quite big. But just the question is about how many of those 160 are really working now as health professionals. Probably most are not. No, again, we do not know, but probably most are not. And that means we are not serving people in Ukraine because we left Ukraine. We are not serving people in Europe because of language, diplomas, whatever reasons exist. And quite likely some people are even dying because of being not served. And one more issue. Just yesterday, American Congress decided to allocate 20 million to account shells. How properly shells used in Ukraine, yeah? But somehow we do not hear that someone tries to account how many of those health professionals are not properly used and what really losses Europe, as a large, is having because of this. So just examples, but really there are issues, hot issues, and it's not about long-term perspective. It happens today. We are losing people and lives today. Just now, as our this event about also politics, long-term politics. So one idea what was quite clear from our research is that European Union is too much caring about health, yeah? We know that it's not in the treaties almost, it's just in this treaty for functioning of Europe, so it's... And also now it's kind of good period because we have a lot of those building blocks, that started on pharmaceuticals, and our issues. It's great, but somehow we do not hear about healthcare workforce. And it's quite clear that to cement those blocks, you need almost for all issues that are going in Europe, you need workers, you need labor, you need professionals. So a proposal would be really to develop one more building block that is dealing with healthcare professionals, and that's exactly a good opportunity for next Parliament, next Council of Europe, next, let us say, Commission.
That's a very valid point, and we want to discuss this in the second panel with VYTENIS and with SARA.
Yeah.
But what we would like to hear from you actually is the situation in Lithuania and how you deal with. I think in the beginning you were referring to that Lithuania is one of the countries that is rather losing health professionals, and your stock of health professionals is not replenished. Like, for example, Germany is also losing, but at the same time there is a lot of inflow. So in the end, it's even a net winner, And I think that Lithuania is a net loser, actually, isn't it?
Yeah, it is, but I would not say that it's very tragic. I would say that issues related to internal movement, those regional inequalities, are much more important for health of people than with international mobility. So just FIM was international mobility, but if to say really what and when we are losing health, I would say that with misallocation or inside the country, especially in primary healthcare, is more important for Holland and for Lithuania. That's the same.
Is the government taking some action to address some of the push factors we've heard from Corinne, like, for example, working conditions, career prospects? What else, Corinne?
Failure of support.
Failure of support.
When you're working in rural and remote areas. Yeah, support networks.
Support networks, yeah, okay.
Yeah, we do, but just as we have little time, so I would like to not to elaborate. Just as my presentation close to the end, so I just like to show this slide here, and we put our findings, on those papers. You may read. Few maybe handouts exist somewhere beyond. So those who would like to look at what we did and what results are welcome to look at documents had been developed.
Thank you so much. Thomas, You have a slightly different perspective on health professional mobility, because you not just have 27 countries plus some associated, you have 53 countries in the mix. And actually, you also have the global perspective on the mobility. Please fill us a little bit on your side.
Thank you, Matthias. Maybe starting by the International Code of Practice that you were mentioning before. You know, it was approved in 2010, so it's been kind of a long way ago. The principles of the code is trying to promote kind of a triple win. So it's a win for the source country, for the health systems in the source country. It's a win for the individuals who are migrating, and it's a win for the health systems in the destination country. I think that that seems very beautiful in a sense. I think it's really difficult to apply in reality, and I think we don't have many success stories of this triple win that the code is promoting. But I think it's good that we have the code in the sense that at least it's bringing these principles of ethical recruitment, but I think we still have kind of a long way to go for the full implementation of the code, and the countries really take this as a key important principle. The application of the code is voluntary, is not compulsory, as many things in this international way. So I think there's an area that probably we need to rethink a little bit how we can make the code more visible, better used by countries. And I think Corinne was raising that when you go out there and you ask for the code, not many people know about the code actually. So I think we also need, because in WHO we tend to talk to each other and then we all know the code, but when you get out of there, who knows the code, which countries are really applying the code, are using those principles. So I'm just raising this question because maybe next year will be the 5th round of reporting of the code, and maybe we have an opportunity to rethink how we can, with increasing global migration, how we can make a best use of the code, or how we can rethink it a little bit.
Thomas, what does ethical recruitment actually mean?
I think it's taking into account these three elements, so that it's not only the destination country benefiting and then you are harming the systems of the source country, but you're taking into account all the different stakeholders here, which are the three that I mentioned.
And
so
there's a list of countries from which you shouldn't recruit because they have workforce shortages.
So last year, it was launched this list of 44 countries with a critical shortage of health workers, which basically is looking at the density of health workers below the average threshold globally, plus looking at the Universal Health Coverage Index. So those countries that are below that one are considered to be in the safeguard list, and then those countries should be kind of protected so that you are not actively recruiting health workers from those 44 countries. None of those countries is in the WHO European region. Most of them are in the African region and also in the Southeast Asia region. Yeah.
But it's still very, very important conclusions coming from this, I think, because it means that, you know, we are talking about our health workforce crisis, about shortages, about the demography, that we need more health workers, but at the same time, the pool, because of the demographic change, the pool of candidates is shrinking. It would not be a viable strategy to recruit from, let's say, Africa or Asia, actually, isn't it?
And I think that's my point. I think there are two ways here. You were talking before, what we see globally is that 4 countries are the main recruiters and count for 75% of all the recruitment worldwide. So we have US, we have Canada, Australia, and then I think it's Canada or France, one of those. I cannot remember exactly now. But what I think is that we need to really encourage that these big countries that are recruiting big numbers, they work more on having sustainable workforces internally, so they are less reliable, they rely less on external countries, which has a huge impact. For Albania, recruiting 50 doctors in a year has a huge impact in the health system. So I think we really need to encourage the big countries first to conduct a labor market analysis so they understand where the shortages and the problems are, looking forward in 10, 15 years' time to see what the needs will be in the future, so that they start building a more sustainable workforce and they rely less in external human resources. And I think some countries are going in the right direction. Ireland, for example, I think they have learned their lesson from the COVID pandemic. A lot of health workers from Ireland are migrating abroad, and they are really trying now. We are doing a case study with them now, and they are really trying to have a more sustainable workforce internally?
I think this is exactly one. We've been talking about future EU health priorities, and I think this will probably be one of those health priorities to really have a timely labor market analysis. Irene, you're starting with this actually. You hear what Thomas is saying. Is it something you could further develop, or your organization would be best suited to do something like this?
Yeah, so this point about try to educate the countries to see what is happening and where are the shortages and where could something done. This is exactly what we intend to do with this analysis. And I think another point also is one of our mandates is to create awareness, to provide information, and also to support the cooperation. So I think we should talk in the coffee break, things like promoting this code and making it more aware for member states. That might be something that we could maybe think about doing jointly. And I think another important point that was raised was maybe we should not only start thinking about the already there doctors, nurses, whatever, but go a step back and go to the education system. So I've heard about stories where the education system brings in foreign students because they have to pay a lot, so it's good for this education center. But then quite naturally they leave again. They get the education in that country, but then they are not the doctors who are working in that country, but they go back to their home country.
Yes, plenty of examples like this, but there are also positive examples. For example, we've been working with Malta, I think like 5-6 years ago, and it's a small country, you know, capacities are limited in terms of training, they cannot train all specialties, but they have collaborations with other countries where their specialists get training episodes, but in a way that they need to come back to Malta actually to finalize their studies. So they cooperate, but they don't lose their stuff. I think this is the things we can really learn from. Corinne, you wanted to come on board.
Yeah, I think that's an excellent example. And I would like to be a little bit blunt here. I'm a health advocate, that's my job. So the fact that we want to raise awareness on the code, we want to raise awareness on understanding the labor market, and doing more on planning and forecasting. We've been doing that for a long time. I mean, the European Commission has invested in a number of joint actions, now also again on a joint action on health workforce planning and forecasting. We do need to continue doing all that, but at the same time, let's not underestimate what the duty bearers already know and what they still keep doing. Because the fact that there are in a database, you know, there are vacancies and there are also a lot of more actually CVs perhaps than vacancies. The CVs of these people are not of people who are unemployed. They are the CVs of people who are working in their country's health system. But they see an opportunity and they jump on it. And of course, countries that receive most of these migrant health workers and social workers, we are not even talking about the workers, the care workers without qualifications. These countries benefit from that instead of investing in their own health workforce, their working conditions.
Thanks.
And that is something that we should really also in the European Union be much more vocal about amongst each other as member states and put much more money into. And it's not even a health agenda, it's an employment agenda.
I think that's one of the messages coming from this panel, that at least the large countries with large labor markets need to be as self-sufficient as possible, because otherwise they will poach away health workers from other countries. Can we give us some time for questions from the audience? Please. You hear the debate. There are some controversies. I guess you have plenty of questions or experience. I see you are almost nervous, George. Yeah,
I am nervous because I'm thinking about how can we talk about this problem from the perspective of the healthcare workers. These are human beings who are wanting to be mobile, who are wanting to move. They're not entering these occupations in order to. Well, maybe they are. Maybe they're entering it to leave their country. Like, what about them? How could we engage with them as advisors or as people to help us solve this problem instead of talking about them as commodities, for example?
Thanks a lot. There's quite some research on it, and if you read the research, you will be depressed because many of these pathways are not very happy, actually, and very often, and this is something also addressed. You know, it's not always the great positions they get in the receiving countries. You know, they become locum doctors or do something problematic. Please.
Thank you, Matthias. Lieve Ministry of Health from Belgium. I was actually just looking into the brief summary reports you presented and into the numbers on not on the health workforce migration, but on the total migration. And I was really surprised by the numbers. And I noted that today we are at around 10 to 15% of the migration compared to 2010, 2011. Apologies. And yeah, if you look at these numbers, then and if you would, I talked to these in Belgium to the minister, then they would say, like, is there still actually a problem on migration or health workforce migration, considering that the total number is so small compared to 10 years ago? Isn't the problem by drying up, simply stated? Thank you.
Thank you, Lieven. So it's about the dynamic of health workforce migration, and we've seen in the past that according to geopolitical issues, it was changing all the time, but apparently it's lower, what you say. But please, first of all, Karin, then Martin, and then we go back to the panel.
My name is Karin. I'm from WHO, Regional Office for Europe. One question that I haven't seen debated here, and I would like to have your views. First of all, I come from the prevention part, and we know that one of the things that that happens in healthcare services is that you keep seeing the same people coming back because they have quite a lot of diseases which are chronic diseases, and it's kind of problems that could have been sorted out before and were not sorted out and are just being a burden to the system and could have been avoided. So therefore, you'd have a healthcare force which could then be more available to treat other people. So the prevention part is not done, and this is an issue that has already been identified. The second is about skill mix. I worked in the African region, and one of the things that I saw quite useful was the use of other professionals to account for the lack of resources in key areas like psychiatrists. I come from the mental health side, but psychiatrists and all of that. We know Brazil, for example, and we heard that already, how the different models using other professionals do have a important role in the community. Pharmacists, we don't discuss the role of the pharmacists and the communities.
Question, Karin?
So my question is, are we considering this type of options?
No, we are not sufficiently. I think that's
that's my question. Thank you for helping me.
Martin.
Yeah, we may disagree on that one, because I think that it's an interesting point, but there's lots of unintended consequences. I'm not saying it's a good idea, but be very careful. No, the question really is work that we've been doing recently, and it's about, we know that there's an issue of retention. It's less recruitment, but retention in high-income countries. So we work in Nigeria, and in the rural health centres that we were working in, we found that the nurses were not coming to work, but there were lots of quote-unquote volunteers. And then we wondered who the volunteers were. And they're all trained nurses. And they're not being paid formally, but they're being paid informally. And the consequence is they get a higher income than they would do if they're being paid formally. And this is work in progress, and we're only beginning to do this. But it does seem to us that in a number of low-income countries, there are actually quite a lot of trained health workers, but the government is not prepared to pay them. And I just wonder if we need to look more comprehensively at this and really question some of the assumptions. As I say, it's work in progress. We've looked at Nigeria, but we've got some indication that this is an issue. Yeah. Not everywhere, but in some other countries. So just putting it out there.
I would agree, Martin, but for us today the question is, do these workers actually end up in Europe? And mostly not, actually, from Africa.
In terms of recruitment.
Yes, yeah. Please, very quick responses from the panel, please.
Yeah, thank you so much. I would like to respond to what Lieven de Raad was saying about the data. For one, in the data, those who are not accounted for are the informal carers. And in the Pillars of Health project, we have done some analysis also of the non-registered professionals that are not registered in the professionals database. And we have come, for example, to numbers in Germany of 300,000 up till 700,000 informal carers coming from Eastern and Southern Europe, Central Europe. Who are in many cases qualified nurses but come to the country to work in home care. So they are not accounted for in the figures. That's one. The second one is indeed true that the internal EU mobility of health and care workers is stabilizing because we have made optimal use of the internal market. So what happens now is that in many countries, including mine, the interest in recruiting health and care workers from outside the EU is now increasing. So we are just moving the problem somewhere else. And we are all facing the shortages, and we're all fishing in the same pond. And instead of working together and making it work for everyone, we keep doing the quick fix.
Irene, can you fill us in quickly on the trends in mobility?
Yeah, what I wanted to react on is this point, could we use others? Personally, I think we're quite rigid in Europe as regards professions and certifications, and thinking kind of out of the box of somebody could do it even if they do not have that certificate that we know. So I think a lot of work has already been done in the EU as regards recognition of skills, notably when we talk about third country nationals, you know, examples that you have brought from America or so from Africa or something. But I think there still needs to be more done to understand that, and something more might happen, because just last year the Commission launched a huge package about skills and having the ambition of working further there. Second point about the undeclared work, or having a possibility to work and maybe earn more than if it was declared. From the worker's perspective, that of course is attractive. You get more money, you don't have to pay a lot of taxes. From the employer's perspective, it might be easier. But I think what we need to work here more from a policy perspective is then to have the longer term perspective, because what it means for the worker, if they work undeclared now, is that they do not accumulate pension rights in the future, or they might not have good health protection or unemployment benefits or later. So I think again it comes back to awareness raising here.
Thank you so much, Irene. Kidimas.
I would like to add to Karina some ideas. That one of problems is that we more or less know about doctors and nurses who are legally employed, but really there is almost no statistics about other health professionals. And today, if you will look to differences between countries for doctors, for nurses, so it's not very big difference. But total healthcare workforce, really we have, if we are taking all people employed, you will see not convergence but divergence in Europe, and that's really should be tackled in the future.
Thanks a lot, Kidimas. And the last final word from you, Thomas?
Just a quick reaction to Martin. I think it's not uncommon to find shortages with unemployment. In many countries we find that. So I think that's an area. But my second point that I wanted to bring is that we also need to work, as you were saying, push factors are the critical factors in individuals to migrate. So I think big work that we have to do is really working on improving the working conditions at home to reduce those push factors so people can really fulfill their professional career in the country. So I think that's one of the things that I would like to pass as well.
Thank you so much, and a big applause to our wonderful panelists. And I would now like to ask SARA and VYTENIS join us here on the panel.
Thank you.
So SARA, thank you so much for making the time and joining us here. Very important, and as you have heard, we've been discussing throughout the entire forum actually health workforce issues. And even though the policy mandate of the Commission with regards to health systems and health workers is very limited. Everybody says we need to do something about it. We need to have transparency. We need to improve working conditions. We need to have best practice, research, all sorts of things. And it's also one of the themes we are discussing with regard to the future health priorities of the European Union. So how is the Parliament thinking about it? How are the fractions thinking about it? Is there some political possibility for this topic?
Let's see. Good morning, everyone. Really important question. So it's important to reflect on what we can do at EU level, and I understand you already discussed this. But one thing that we managed to achieve this legislature at the European Parliament at the EU level is to go further beyond on Article 168 on protection of public health. So this mandate, with a big push from the pandemic, we managed to improve and work towards a European Health Union, exploring the part where protection of public health is a shared competence between European Union and the 27 member states. What we're talking here is that provision of healthcare, how each member state provides its care, how each member state organizes its health systems, is national policy. But what we can do at EU level, and we have directives that recognize speciality and improve or work towards better mobility around the workforce. What we cannot do is to think that 27 health systems can work in silos when we are speaking about the European Health Union and the European Union. We have the Cross-Border Health Directive. We have the improved Serious Cross-Border Health Threats Directive. But unfortunately, what I must say is that this issue about the health workforce that I heard the panel just referring is not high on the agenda. And it's something we need to recognize, because if we want to protect public health, we cannot do it with only primordial prevention. We need our health workforce, and that is something that should come up high in the agenda, and hopefully perhaps at the next EU elections discussions.
So you think we need to have this topic already in the run-up to the elections, and it needs to be discussed publicly?
I think we need to be very frontal and open about it, because looking back on 2019, when I started in the Parliament, everybody would say, oh, health is not a EU competence. What is a medical doctor doing there? And we actually managed to build so many regulations and directives to improve public health across the EU. So this is not something that we can, a taboo topic. We need to start discussing this, but still there's not much discussion going on it at Parliament.
One of the lessons from COVID-19 is that even with a limited health mandate we have at the moment, if there's political will, we can do a lot actually. A lot can be addressed and a lot has been done. So the question is, Sarah, and that's a question for you, do you think there's a chance to get some political will for health workforce action in Europe to go beyond what we have at the moment, to further build on the European Health Union?
Yes, I think so, because that's not a problem of one or two member states. It's a problem that affects the whole union and the provision of care of 450 million. And here I believe we can explore the protection of public health part, and this is where it goes further on, and where we can actually have a EU approach to this issue.
And may I ask you about the political families in Europe? Do you think there will be enough consensus across the different parties?
So actually, I'm a bit. So what we see at the Parliament is that there's a lot of will to work on health issues, but part of the Parliament, I would say, tries to focus on disease and how to overcome disease, whereas other part of the Parliament tries to go further and tries to work on prevention and promotion of health, preventing disease. If we are going to agree on consensus, it depends on the elections. I'm quite worried about the elections, because I'm worried about the lack of of ambition when it comes to tackling other determinants of health. We saw that with the climate change, with the nature restoration law. We saw it with the air quality directive. Air quality air pollution causes 10% of cases of cancer. We have the biggest political group being a champion on fighting cancer. Yeah. However, they voted against the directive that will improve air quality. So this is what we have at the Parliament, and I believe we should move beyond just discussing disease and start discussing truly about health.
Very good, thank you so much. VYTENIS, former Minister of Health, former Commissioner for Health in the European Commission, and you are the main driving force behind European Health Union initiative. And I know that you are not satisfied yet what has been achieved, even though quite a lot has achieved, and we need to acknowledge this. What shall we do next, VYTENIS? What's next?
Thank you, Matthias. First of all, thank you for your efforts always to keep healthcare workforce shortages on top. And now, you know, it's a very simple question to all of us. In some regions, in some municipalities, in every country, people can ask you, look, you are speaking about doctors. Oh yes, there are so few, so far, and so old. And what they can think about European Union in some part of Portugal, in my country, in Romania. They think that, look, our doctors, our nurses are going into richest countries and they are voting in favor of Eurosceptics. This means it is problem of integration of European Union. Why am I arguing about possibilities to include health into treaties, especially into treaty of the EU, because health till now is ancillary issue. At EU level, Matthias, it's not an aim as a treaty, not an aim. Health as common definition, because this definition is very, very complex one. It is an aim.
But what do we next? What do we next? What do we do next, VYTENIS?
We need to press now. We need to send political messages now in front of new European Parliament elections. And let me quote Ursula von der Leyen. You heard it. She told in State of the Union, she told, and yes, that means including through a European Convention and treaty change if and where it is needed. If and where it is needed. Debates about treaty changes are needed now in front of new parliamentary elections.
But VYTENIS, even if we get a treaty change, that would take years, you know, and the workforce crisis is here, so we need to do things quite quickly.
Matthias, you are right. We need to work now. We need to have three scenarios. Scenarios one, scenarios A, to do business as usual, but drawing priorities. Scenario B, to implement much more energetic, especially problems about health crisis, using secondary legislation, using European semester instruments. We have possibility. And scenario 3, we need to also to press very much that we need to strengthen constitutional frame which can help us to encourage member states to cooperate, keeping in mind shared competences in the health.
Thank you, VYTENIS. Can we have 3 quick questions for our wonderful panelists before we close the session? 3 quick questions, and I need a roving microphone, please. Nobody is tempted to ask a question. That surprises me. Corinne, well, I know you are. Anybody else? Yes, please, Rika. You can give it to me. Please introduce yourself.
Thank you very much. I'm Rika Kovács from Hungary Semmelweis University, but previously I worked on health workforce issues for many years in the Ministry of Health. And I participated in many debates about mobility during the Hungarian presidency in 2011. And we are still saying the same things. And I'm really very much interested in how would it help the situation if we change the treaty? How could we better build on the ethical principle of not recruiting from poorer European countries to Western European countries? Thank you.
More questions? You're still tired? So, there, Lieven, yes, please.
It's a comment on the discussion of treaty change or not. For me, the health workforce issues, and it's, I think, a bit what you were saying, it's about wages, working conditions, and by changing treaty or not, I don't see how that's going to change this. Thanks.
Thanks, Lieven. So that's a little bit what we discussed in the first panel, that many of the problems are domestic problems, actually, with regards to working conditions, for example. Corinne, last question, and then we go back to the panel for the final round.
Yeah, it relates also to Lieven's question, but also to what Ms. SARA said. It's the mandate of the national member states to take care of health and health issues and health and care workforce within their own capacity. But you could argue, and I would like to hear your reflection on that, you could argue that member states are undermining each other's capacities by using the health and care workers that they have recruited from those countries. And I fail to understand why member states do not hold each other to account on this. For example, by very simply reporting on an indicator that says something about the reliance on foreign-trained and foreign-born health and care workers.
Thank you so much. So that would be definitely a role for Europe. And Irene, we were talking about bringing transparency to the European labour market, actually. Please, Sarah.
Yeah, really great questions and remarks. I will start with even before speaking about treaty change or starting those discussions, I would say that we can still, at EU level, help work into making health systems more resilient. And actually, that's one of the goals of the EU for Health Programme, the European Health Programme 2021-2027. On the different indicators, that's very interesting. Yeah, I come from a country where it's going through that scenario now. A lot of the health workforce is leaving. But what I truly think, and I would like to reflect, is that at the EU level, obviously we need more indicators, but again, we need to also work into making the health systems more resilient and the health systems more attractive, work conditions more attractive, and as we do with other health policies, perhaps create a best practice interchange within member states. But I truly believe that, and then reflecting on the discussions that were on 2011, it will be interesting to see what the Council has to say on that, because what we see is that not much has changed in the last decades or so.
Sarah, thank you so much. Thank you so much for joining us, and thank you so much for being so open and frank and giving us some insights about the Parliament and what might be coming next. And now the final contribution from your side, VYTENIS. You deserve it because you're really the driving force behind all this. But still, I have to ask you to be very brief because we are already running out of time.
Very brief. Please send clear message to the next parliamentary election. We need to have additional 6 building blocks using the same illegal instruments which are now allowed to build block about healthcare workforce shortages and healthcare systems resilience. To have separate block. Now we have block on the cancer, we have block on pharmaceuticals, we have block on preparedness, we have block on long-term care, and we have block on mental health. Now it's time immediately to have additional block, keeping in mind the same concept like today European Health Union. We need this immediately, otherwise time to act, as WHO calls for all member states, that we can face big healthcare systems crisis because of healthcare workforce shortages and of course lack of understanding. Second issue, we need also to understand if we will have shared competences, we can change game, speaking about timing, implementation, and so on. Especially also one issue, people think about bad feeling. They have no access to innovative treatments, equal access to innovative treatments. If innovative is placed in
but that's not the workforce right now.
But it's the same speaking about the health,
yes.
The same speaking about possibilities to raise health as an aim, as a third pillar in the EU, because now is internal market, banking and monetary union, defense and security union, and no one word about health and well-being union. That is what people are thinking about.
VYTENIS, thank you so much. And I think an additional building block for the European Health Union would be great on health systems and the health workforce. And a big applause for our wonderful panelists. Thank you so much.